Inspection. Observe the rate, rhythm, depth, and effort of breathing. A healthy resting adult breathes quietly and regularly, about 20 times a minute. Inspect the patient's color for cyanosis, such as the shape and color of the fingernails. Palpation. Place your thumbs at about the level of 10th rib. Place your fingers loosely, grasping and parallel to the lateral rib cage. As you position your hands, slide medially just enough to raise a loose fold of skin between your thumbs over the spine. Watch the distance between your thumbs as they move apart during the inspiration and feel for the range and symmetry of the rib cage as it expands and contracts. Ask the patient to repeat the words 99. Use both hands to palpate and compare symmetry areas of the lungs. Percussion. Percuss one side of the chest and the other side at each level in ladder-like pattern. The thickness of the muscle and the bone alters the percussion notes over the lungs. Identify and locate the area and quality of any abnormal percussion note. Auscultation. Listen to the breath sounds with the diaphragm of the stethoscope. Always place the stethoscope directly on the skin. Use the ladder pattern moving from one side to the other. Breath sounds. First one is the vesicular breath sound. These are soft, low pitched, heard during inspiration. Their inspiratory sounds last longer than the expiratory sounds. Next, the bronchovesicular sounds. These are heard in the first and second interspace anteriorly between the scapula posteriorly. They have intermediate pitch and intensity. Inspiratory and expiratory sounds are almost equal. Bronchial sounds are loud, higher in pitch, heard over manubrium. Expiratory sounds are longer than the inspiratory ones. The last one are the tracheal sounds are very loud and relatively high in pitch. They are heard over the trachea in the neck. Inspiratory and expiratory sounds are almost equal. The adventitious sounds are superimposed on the usual breath sounds. It is an important focus of your examination. The most common adventitious sounds are crackles, wheezes, and ronki. Coming to the crackles, they are intermittent, non musical, and brief. These are heard in pneumonia, fibrosis, and early heart failure. Wheezes are high pitched with wheezing quality. Wheezes are often suggest an asthma. Ronki are low pitched with snoring quality. These are from secretions in large airways. Transmitted voice sounds, egophony. Ask the patient to say E. You will hear a muffled long E sound. Next, the bronchophony. Ask the patient to say 99. Normally, the sounds transmitted through the chest wall are muffled and indistinct. Next, the whispered pectoroloquy. Ask the patient to whisper 99. The whispered voice is normally heard faintly and distantly, if at all. Coming to the examination of anterior chest, the inspection. Observe the shape of the patient chest and the movement of the chest wall. Palpation. Place your thumbs along each costal margin, your hands along the lateral rib cage. As you position your hands, slide them medially a bit to raise a loose skin fold between your thumbs. Compare both sides of your chest using the ball or the ulnar surface of your hand. Percussion. Percuss the anterior and lateral chest on both sides. In a woman, to enhance percussion, gently displace the breast with your left hand while percussing with the right. Ask the patient to move the breast for you. Auscultation. Ask the patient to breathe deeply with mouth open. Place the diaphragm of the stethoscope. Listen to the chest anteriorly and laterally in ladder-like pattern.